Now let us see distribution of the drug from pharmacokinetics. Once the drug has gained access to the bloodstream, it gets distributed to other tissue that initially had no drug concentration gradient being in the direction of plasma to tissues. The extent of distribution of a drug and its pattern of tissue distribution depend on its lipid solubility, ionization at physiological pH, a function of its pKa, extent of binding to plasma and tissue proteins, presence of tissue specific transporters, differences in regional blood flow, movement of drug proceeds until an equilibrium is established between unbound drug in plasma and tissue fluids. Subsequently, there is a parallel decline in both due to elimination. Apparent volume of distribution AVD. Presuming that the body behaves as a single homogeneous compartment with volume V into which the drug gets immediately and uniformly distributed, AVD is equal to dose administered intravenously divided by plasma concentration. Since the example shown in figure 2.8, here is figure 2.8, total drug in the body is 1000 mg in the blood. Plasma drug concentration is 50 mg, so apparent volume of distribution is dose upon plasma concentration, that is 1000 mg upon 50 mg per liter. So apparent volume of distribution is 20 liter. In this example, 100 mg of drug injected intravenously produced steady state plasma concentration of 50 mg per liter. Apparent volume of distribution is 20 liter. The drug does not actually distribute into 20 liter of body water with the exclusion of rest of it. It is only the apparent volume of distribution which can be defined as the volume that would be accommodate all the drug in the body if the concentration through was same as in the plasma. Thus it describes the amount of drug present in the body as a multiple of contained in a unit volume of plasma. Drugs with large molecular weight or high plasma protein binding do not enter the cell and remain largely in the plasma. For example, dextrin, which has large molecular weight, heparin, which is more than 99% plasma protein binding, has apparent volume of distribution 0.05 liter per kg, that is plasma volume only. The lipid insoluble drugs neostigmine, gentamicin have restricted entry into the cell. Their apparent volume of distribution approximates extracellular fluid volume of 0.2 liter per kg. Lipid soluble drugs diazepam can cross the lipid bilayer and get uniformly distributed in the body, therefore have apparent volume of distribution of total body water, that is 0.65 liter per kg. Drugs which are extensively bound in the cell or tissue get sequestered, result in low plasma concentration and thus have physically impossible apparent volume of distribution, that is more than 1 liter per kg. For example, digoxin binds to heart and muscles and has apparent volume of 6 liter per kg. Factors governing the volume of drug distribution: lipid, water partition coefficient of the drug, pKa value of the drug, degree of protein binding, affinity for different tissues, fat, which is lean body mass ratio, which can vary with age, sex, obesity, etc. Disease like CHF, uremia, cirrhosis, clinical significance of volume of distribution. In case of poisoning, drugs with large volume of distribution are not easily removed by hemodialysis as they are sequestered in the tissues. Pathological state, for example, congestive heart failure, uremia, cirrhosis of liver, etc., can alter the apparent volume of distribution of many drugs by altering the distribution of body water, permeability of membrane binding protein, or by accumulation of metabolites that displace the drug from binding sites. Redistribution. Highly lipid soluble drugs get initially distributed to organs with high blood flow, that is, brain, heart, kidney, etc. Later, less vascular but more bulky tissues, for example, muscle, fat, take up the drug, plasma concentration fall, and the drug is withdrawn from the highly perfused site. If the site of action of the drug was in one of the highly perfused organs, redistribution results in termination of drug action. A relatively short hypotonic action lasting 6 to 8 hours is excreted by oral diazepam or nitrazepam due to redistribution despite their elimination half-life of more than 30 hours. Penetration into the brain and CSF. The capillary endothelial cells in the brain have tight junctions and lack large paracellular spaces. Moreover, an investment of neural tissue, which is shown in figure 2.9b. This is figure 2.9b, which has tight junction, basement membrane. Here is the basement membrane. Then lipid insoluble polar drug does not penetrate here. Lipid soluble non-polar drug will penetrate glial cell process or choroidal epithelium, which lines the endothelium of the capillary. This is the brain capillary versus this is the usual capillary, which has intracellular pores, basement membrane. Here the lipid insoluble polar drug can penetrate along with lipid soluble non-polar drugs. Passage of drug across the capillary. A is usual capillary with large paracellular space through which even large lipid soluble molecule diffuses, whereas B is the capillary consisting of blood-brain or blood-CSF barrier, tight junction between the capillary endothelial cells and investment of glial process or choroidal epithelium do not allow the passage of non-lipid soluble molecules or ions. Covers the capillary. Together they constitute the so-called blood-brain barrier BBB. The similar blood-CSF barrier is located in the choroidal plexus, where capillaries are lined by choroidal epithelium having tight junctions. Both these capillary have lipoidal and limit the entry of non-lipid soluble drugs, for example streptomycin, neostigmine, etc. Only lipid soluble drugs therefore are able to penetrate and have action on the central nervous system. In addition, efflux transporter like PGP and anion transporter or ATP present in blood and choroidal vessels extrude many drugs that enter the brain and serve to augment the protective barrier against potentially harmful xenobiotics. Dopamine does not enter brain, but its precursor levodopa does. As such, later is used in Parkinsonism, inflammation of meninges or brain, increased permeability of these barriers. There is also an enzymatic BBB monoamine oxidase, MAO, cholesterase, and some other enzymes are present in the capillary wall or in the cells lining them. They do not allow the catecholamines 5-hydroxytryptamine and acetylcholine, etc., to enter the brain in the active form. The BBB is deficient as at the chemoreceptor trigger zone in the medulla oblongata. Even lipid insoluble drugs are emetic, and at certain periventricular sites like anterior hypothalamus, pineal gland, subfornical and subcommissural areas. Exit of drugs from CSF and brain, however, is not dependent upon lipid solubility and rather unrestricted. This is due to bulk flow of CSF along with drug dissolved in it back into the blood through arachnoid villi. In addition, non-specific organic anions and cation transport processes similar to those in the renal tubule operate at the choroidal plexus. Clinical importance of blood-brain barrier. Lipid-soluble drugs have CNS effect. Diazepam quaternary compound, which are lipid insoluble, do not produce significant CNS effect, for example, neostigmine. BBB permeability increases with inflammation, meningitis, and even lipid insoluble drug can move across the barrier, for example, penicillin in bacterial meningitis. Fourth, lipid insoluble drug do not produce certain effect by acting at the site where BBB is deficient. Passage across the placenta. Placental membrane are lipoidal and allow free passage of lipophilic drugs while restricting hydrophilic drugs. The placental efflux, PGP, and other transporters like BCRP, MRP3 also serve to limit fetal exposure to maternal drug administered drugs. Placenta is the site for drug metabolism as well, which may lower or modify exposure of fetus to the administered drug. However, non-lipid soluble drugs, when present in high concentration or for periods in maternal circulation or for long periods in maternal circulation, gains access to the fetus is restricted amount. Thus, placenta is an incomplete barrier and almost any drug taken by the mother can affect the fetus or the newborn. For example, morphine drug delivery can produce respiratory depression in newborns. Plasma protein binding. Most drug possesses physiochemical affinity for plasma protein and gets reversibly bound to these. Drugs which highly bound to plasma protein, to albumin, valproic acid, benzodiazepine, NSAIDs, phenytoin, penicillin, sulfonamide, tetracycline, warfarin. To alpha-1 acid glycoproteins, beta blockers, bupivacaine, lidocaine, imipramine, methadone, prazoin, quinidine, verapamil. Acidic drugs generally bind to plasma albumin. Basic drugs to alpha-1 acid glycoprotein binding to albumin, which is more abundant, is quantitatively more important. Extent of binding depend upon the individual compound. No generalization for pharmacological or chemical class can be made. Even small chemical change can markedly alter protein binding. For example, binding percentage for some benzodiazepines is flurazepam 10%, lorazepam 90%, alprazolam 70%, diazepam 99%. Increasing concentration of drug can progressively saturate the binding site. Fractional binding may be lower when large amount of drug are given. Generally expressed percentage binding refers to usual therapeutic plasma concentration of drug. Clinically significant implication of plasma protein bindings are high plasma protein bound drugs are largely restricted to vascular compartment because protein binding drug does not cross membrane except through the large paracellular spaces such as in the capillaries that tend to have smaller volumes of distribution. Second, the bound fraction is not available for action. However, it is an equilibrium with the free drug in the plasma and dissociate when the concentration of the latter is lower due to elimination. The plasma protein binding thus tantamounts to temporary storage of the drug. Third, high degree of protein binding generally makes the drug long acting because bound fraction is not available for metabolism or excretion unless it is actively excreted by liver or by kidney tubules. Glomerular filtration does not reduces the concentration of free form in the afferent vessels because water is also filtered. Active tubular secretion, however, removes the drug without the attended solvent. Concentration of free drug fall beyond the drug dissociates and is eliminated, resulting in the higher renal clearance value of the drug than the total renal blood flow. See figure 3.3. Example, excretion of penicillin, elimination of half-life is 30 minutes. The same is true for active transport of highly extracted drug in liver. Plasma protein binding is the situation, acts as a carrier mechanism and hastens the drug elimination. Highly protein bound drugs are not removed by hemodialysis and need special techniques for treatment of poisoning. Fourth, the generally expressed plasma protein concentration of drug refers to the bound as well as free drug. Degree of protein binding should be taken into account while relating this to concentration of the drugs that are active in vitro, for example MIC of antimicrobial. Fifth, one drug can bind to many sites on the albumin molecule. Conversely, more than one drug can bind to the same site. This can give rise to displacement interaction among drugs bound to the same sites. The drug bound with high affinity will displace the bound with lower affinity and tend to increase the concentration of its free form. This, however, is often transient because the displaced drug will diffuse into the tissue as well as get metabolized or excreted. The new steady state free drug concentration is only marginally higher unless the displacement extends to tissue binding or this is concurrent inhibition of metabolism and or excretion reducing drug clearance. The overall impact of any displacement interaction is minimal except when the interaction is more complex. Moreover, the highly bound drugs do not necessarily displace each other. Their binding site may not overlap. For example, probenicide and indomethacin are highly bound to albumin but do not displace each other. Similarly, acidic drugs do not generally displace basic drugs and vice versa. Drug concentration in the tissue. Skeletal muscle and heart, digoxin bound to muscle protein; in liver, chloroquine; in the kidney, chloroquine and amantine; thyroid, iodine; brain, chlorpromazine, isoniazide, retina chloroquine bound to nucleoproteins, iris ephedrine atropine bound to melanin, bone and teeth tetracycline heavy metals bound to mucopolysaccharide of connective tissue, biphosphonates bound to hydroxyapatite adipose tissue, thiopentone ether, minocycline DDT dissolved in neutral fat due to high lipid solubility remains stored due to poor blood supply of fat in the adipose tissue. Fourth, hypoalbuminemia binding may be reduced and higher concentration of free drug may be attained. For example, phenytoin and furosemide. Other disease may alter the drug binding. For example, phenytoin and pethidine binding is reduced in uremia. Propranolol binding is increased in pregnant women and in patients with inflammatory disease. Acute phase reactant alpha 1 acid glycoprotein increases tissue storage. Drugs may also accumulate in specific organs by active transport or get bound to specific tissue constituents. Drugs sequestrated in various tissues are unequally distributed, tend to have larger apparent volume of distribution and a longer duration of action. Some may extend local toxicity due to high concentration. For example, tetracycline on bone and teeth, chloroquine on retina, streptomycin on vesicular apparatus, emantine on heart and skeletal muscle. Drugs are also selectively bound to specific intracellular organelles. For example, tetracycline to mitochondria, chloroquine to nuclei.